We're really happy to see you here today. Thank you so much for braving the intermittent inclement elements to join us here for this briefing. This convening is part of a regular series of briefings that the California Healthcare Foundation sponsors for Sacramento policy staff and other interested persons. My name is Kate O'Malley. I'm a Senior Program Officer with the California Healthcare Foundation. Today's topic is focusing on exploring the need for a POLST registry in California. When you came in, hopefully you all took an opportunity to pick up a packet, which has an agenda for today, and some supplementary materials that you may find of interest, including some background research related to the effectiveness of POLST, and also a POLST form, if you're not familiar with what this actually is, the physician order for life-sustaining treatment form that's widely used in the state of California. For people listening on the webinar and on the phone, all the materials that are available to people here in person today are also on the California Healthcare Foundation website. So we invite you to go there to get copies of the slides and also all the supplementary materials. So a little bit about the California Healthcare Foundation's interest in this topic. As part of our strategic efforts to promote more appropriate care towards the end of life, we've long appreciated the value of including the voice and the perspective of the individual in healthcare decision-making, particularly as applied to POLST, people with serious illness, for whom these decisions are timely and more immediate. When we were looking for a way to promote a practice that we could use in California, we looked to our neighbors to the north, who had been pioneering the physician orders for life-sustaining treatment for about 20 years. And through the mentorship and advice and example and experience of our neighbors in Oregon, we were able to apply and accelerate a lot of the uptake and application of POLST in California. In 2007, the California Healthcare Foundation funded the Coalition for Compassionate Care of California and 7 local coalitions to really explore the idea of the readiness of California to try to implement POLST here in the state. Since then, that effort has grown to encompass a statewide task force of individuals who have an interest in the topic, representing many agencies and organizations, and over 25 local coalitions who champion the adoption of POLST at the local level. In the ensuing years, we've seen a dramatic increase in California about the awareness of the POLST form, the value of it, and its uptake in the state. The presentations of our speakers today will cover a health plan's perspective on the value of a POLST registry, an overview of POLST as a process to capture individual wishes for intensity of care, and also what we know about POLST in California from research that we have been sponsoring for several years. And also we'll hear about the experiences of the Oregon POLST Registry, which I'm pleased and delighted celebrates their 5th year anniversary today. So we'll be hearing 5 years of their utilization experience of a registry in the state of Oregon. We're really pleased to have you join us today to learn about the potential to improve communication and improve access to information about individuals' health wishes in the context of serious illness at a time when communication is vital and when people are very vulnerable. Today, we're also joined by over 300 people who have signed up through WebEx and phone, both statewide and nationally, to hear about this important information. The phone lines, unfortunately, are muted. So the value of showing up is you get to ask questions at the end in person, and we really appreciate you being here. So we're videotaping this event today, and this videotape will be available on the Foundation website probably by Friday, along with all the questions and answers from our audience today. So without further ado, I'm going to turn it over to our moderator, Dr. Robert Moore, who's the Chief Medical Officer for Partnership Health Plan that serves 14 Northern Californians counties and has about 500,000 members. And Bob has been very active in the statewide POLST efforts over the past several years with a very strong interest in the utility of a registry to improve the communication that's captured during the POLST conversation and on the forum. So I'll turn it over to you, Bob, and again, welcome.
Thank you, Kate. And I'd like to thank the California Healthcare Foundation for putting on this very important legislative briefing to really bring us up to speed on this critical topic. As Kate mentioned, my name is Dr. Robert Moore. I'm a family physician, and I am on the board of the Coalition for Compassionate Care of California, and have been on we've had a POLST registry work group, which has been sort of trying to get together stakeholders to look at this issue for the past year and a half or so. So it's an issue that's very important to me. I'm also the Chief Medical Officer of Partnership Health Plan, as Kate mentioned. I'm also a family physician. I still see patients actually on about once a week at a community health center in Napa, and still work in the hospital. So I have a chance as a frontline clinician to use the POLST to see what it means in action. I'll talk a little bit about that in just a second. So let me. Sure, I apologize. I'll have to lean over. So before I just give my introductory thoughts about the POLST and turn it over to the speakers, I wanted to just give an idea of get us all on the same page with the use of the word registry. Registry has the term registry has many different meanings, and it's important to kind of understand what we mean when we're talking about a POLST registry. So to give a little perspective, we have this one slide sort of summary that kind of gives you a sense of the different ways the term registry is used and where it fits in. The first way that the term registry is used is to think about looking at population issues when we want to look at problems that affect the entire state or the country. And its purpose is to really figure out what causes disease or what factors can help with diseases. And a couple of examples: in California, there's a cancer registry that every individual diagnosed with cancer is required by law to have the organization that diagnoses them, whether it's a hospital or so on, must report that information. And then there's a follow-up to try to see what the natural history of that disease is, to give us information on the natural history of the different types of cancer. There's also a national ALS registry. In fact, there are many registries. The federal government has set up a master registry site. There's a registry for chromium exposure and lead exposure. There's a variety of different registries for exposures to different types of condition. And those are, again, that purpose of that is to really understand how disease works. Another way to look at a registry is when you look at a specific segment of the population is to use a registry to drive quality improvement or quality performance improvement. A couple of examples. One in California is the California Perinatal Quality Care Collaborative, which is involved with both quality improvement, and that's their main mission, but also they use a registry of gathering data on perinatal statistics to help use to inform those efforts. There's also the California Joint Replacement Registry, which is a project of the California Healthcare Foundation and the Pacific Business Group on Health, which seeks to gather data on joint replacements and to look at the outcomes with that. Interestingly, that particular registry also allows patients to enter information, which is interesting, another variation on the registry. The type of registry that we're thinking about with the POLST registry is really a transactional registry, which is something that, as opposed to just sending in information about cancer and having it wind its way into a database that's analyzed and fed back on a website years later, is meant to be accessed and used in close to real time. One example, there's several examples listed on the slide. The death registry, a particularly important one is the California Immunization Registry, where immunization providers enter immunizations as they're given. So and wherever a child goes throughout the community to get their vaccinations, the registry has all the information. So it's not just sitting in one particular office. Another good example that's been in the news recently is the Controlled Substance Utilization Review and Evaluation System, the CURE system, where pharmacies report a registry of every patient who fills a medication for controlled substances, and that is accessed by healthcare professionals in an effort to try to prevent abuse of medications and so on. So those are the different types of registries. Before I turn it over to Judy to give more detail about the POLST system in California, let me just reflect a little bit as a physician what the registry means. Or what a registry might mean. I've had a chance to help patients fill out the POLST form and see them being discussed when patients are admitted to a hospital, and I've heard stories and have seen individuals whose wishes were not known at the time they were arriving at the hospital, or the emergency medical services did not know those wishes, even though we have this system in place. And as a result, they had care that they didn't want to have happen occur to them. And it's heartbreaking for both them and sometimes their families as well to have that happen. And so having a POLST is great, but having it available and accessible and high quality is really a critical piece. In terms of my role as a health plan, Kate mentioned what is the interest of health plans in a registry? I think as a county organized health system, our mission is not just to serve our members, but to serve the greater community. And I think this falls in that side. To me, a POLST registry is sort of a public health issue. It's in the sense that we need to use that kind of logic in thinking about it rather than a financial issue. We really need to look at it as a patient autonomy issue and in a way that we can really honor individuals' choices when they have expressed those choices and make sure that they're followed. High quality conversations are obviously a critical part of that. So that's my interest in this. Let me introduce the next speaker, who is Judy Thomas. Judy is the Executive Director of the Coalition for Compassionate Care of California, a statewide collaboration of healthcare providers, consumers, regulatory agencies, working to improve the care of seriously ill Californians. She's also the lone attorney on our panel up here of three doctors, and she's worked in healthcare for many years. And she was really on the front lines when the POLST in California first came into existence, and saw the entire process as it wound its way through the legislature. So she's been firsthand and is a really knowledgeable expert on the POLST in California. So she'll be telling us a bit more about that history.
Thank you. And I was told to speak close to the mic, so people who are not physically here can hear us well. But thank you all for being here today, and those who are calling in. POLST is been a major part of my life, along with Kate O'Malley's, since 2007. And so we're excited to be able to share POLST with you. We believe that POLST has been tremendously successful in California. POLST is a national program, but in California, the program here has really moved it farther, faster than other states, because we've been very strategic and collaborative in how we've worked through this, and there's quite a bit of infrastructure that supports POLST here in California. So what is POLST? POLST is a form, POLST is a process, and POLST is a community. Starting with the form, people think of it, and it is a physician's order for life-sustaining measures. It's brightly colored. There's one form for the entire state of California. It's bright so that it stands out in the medical record so you can find it right away. And the whole point of it is patient-centered. It documents what the patient wants for their care. And it provides direction to healthcare providers in that critical moment when the person cannot speak for themselves. They have the medical order, which allows them, because the EMS has authority to honor physicians' orders. So POLST is a medical order that the whole team, healthcare team, can honor. Here's a copy of the POLST form. This is the front of it. Everything that you need to know to determine whether this is valid and actionable is on the front of it. Sections A, B, and C are the treatment wishes. Section D are the signatures. It requires both the individual and their doctor, and to be dated. On the back of the form are instructions and additional identifying information. And it is still required to be honored even if it's not the bright pink color. So POLST is one part of advanced care planning of a larger process that happens over time. So advanced care planning is the process of thinking about your wishes, talking to your loved ones, and putting it down into writing so healthcare professionals can honor it. We recommend that everyone who's 18 years or older have an advance directive. And that's the way to name who you want to speak for you. And that you review that and update it as your life changes, as your medical condition changes. And then when you get towards that late life where you have a serious illness, it's starting to deteriorate, that's when it's time to go to your doctor and talk about the possibility of having a POLST form. And you can see on the left side here, going down this timeline, is conversation. Conversation is a really important part of advanced care planning. And the document itself is only as good as the conversation behind it. And our goal at the end is that individuals get their treatment wishes honored. So POLST is designed for people who are seriously ill, have an advanced chronic illness, medically frail. You wouldn't be surprised if they died in the next year. An advance directive, in comparison, is for any adult who's 18 years or older. POLST is a physician's order, so it's grounded in that relationship with that physician, with the conversation with the physician, as well as the team, but the physician signs it. And the conversation should be grounded in the person's diagnosis and prognosis. An advance directive, an individual can put anything they want in their advance directive that they think might be helpful for the medical team and for their agent to know about their wishes. And when it talks about treatment wishes in an advance directive, it's usually hypothetical and far in the future, whereas POLST is, given my medical condition today, if I went to the hospital, what would I want? The advance directive is the way to name your agent. The POLST can be signed by the agent. So an advance directive, once an individual loses capacity, they can't have an advance directive because it has to be, it's that individual's document. But with POLST, it's both the individual can execute it with the physician, and then once they lose capacity, the agents can continue to update that in collaboration with the medical team to continue reflecting the individual's wishes based as their medical condition progresses. And I just want to point out again, POLST is not about foregoing treatment, it is about the patient's wishes. So now we have a quick video here.
I think it's very beneficial for a caregiver, a physician, to talk to their patient about an advance directive or end-of-life care. If medical decisions are made without the patient's input, I believe that wrong decisions may be made. There would be bad feelings among family and friends. If there was the opportunity to talk to my brother 21 years ago about end of life, I think we would have done it. Reality at that time, 21 years ago with AIDS, there was hardly any hope. Advance directives weren't as well known. I think it would have made things a lot easier. I think that in the Asian community, end of life discussions are not talked about. It may be changing with the younger generation, but we're still taking care of our older parents who don't want to talk about death. A discussion regarding end-of-life care with my mother was not a lengthy one. It was done in the doctor's office. It was a very short discussion, but I do know that she doesn't want dialysis and she doesn't want any heroic measures. If you want your wishes honored at end of life, I think you should have an advance directive now. Now is not too soon. I think you should speak to a friend after you've made that advance directive and make it known to that friend on what your wishes are and have that advance directive in your medical chart in the hospital. I did it for myself because I wanted to make it clear that if I'm close to end of life, that I don't want any heroic measures for myself and I just want to go.
So as I mentioned, POLST is much more than a form. It really is a process and a conversation that happens between the patient and the medical team and the doctor, as well as the individuals, the patient's family members. So here in California, when we brought POLST to California, we put a lot of infrastructure in place, and the California Healthcare Foundation deserves a lot of credit for providing financial and other operational support to make that possible here in California. So these are a number of the entities that are involved. The Coalition for Compassionate Care is the lead here. But we also have the POLST Task Force, which is made up of 35 stakeholder organizations. We have our Physician Leadership Council, which is made up of 25 physicians who meet every month to talk about how to sustain the integrity and the physician aspects and components of the POLST Forum. We have 25 local coalitions around the state we work with, and we have hundreds and hundreds of POLST trainers. So this is a map showing where the 25 local coalitions are based. Because California is so large, that is something that we felt was a hallmark and a key part to bringing POLST in California, because we need to have this infrastructure at the state level as well as the local level. So they're on the ground working with POLST and making sure that it gets implemented in the community, and that all of this is around maintaining the quality and the integrity of the POLST program. POLST is a powerful tool, and it needs to be used properly, and it needs to be used to reflect patients' wishes. So to maintain that quality, we look at training. We have here, for those who are in the room, you can see our binder for our training on the POLST conversation. We look and review and update the form. We had some changes that went into effect October 1st. We have frequently asked questions. We have decision guides. We have videos. We have ethnographic research. And all of this is devoted to maintaining the integrity and the quality of the POLST program. So POLST became law in 2008 with AB 3000, which did establish it in law, which was helpful, a key piece that allowed us to spread this statewide all at once. So now we're at the point where we're looking at, would a registry be beneficial? And here are some of the reasons that it would allow access to these forms at the moment when they're needed, because these decisions, people make these decisions in advance, and the healthcare providers often have to act on it in a split second. It reduces moral distress among our healthcare system and our healthcare providers to know what patients' wishes are. It can also create a process for completion of the form that helps to assure the quality of it, double checking to make sure the signatures are there, double checking to make sure that the choices are concurrent, are consistent. And it also allows for research so that we can understand what's going on with POLST in California better than we can now. So there's a lot of interest in electronic registries for advanced directives in general. POLST is particularly ripe for a registry in a way that advanced directives aren't. One, because it's targeted to those people who are late stage. They are the ones who are likely to end up in the hospital. It's a medical order. It can be acted on. It's standardized. And there's a community that owns POLST that will be able to make sure that forms get put in and that forms are pulled out, rather than just relying on patients to take the action themselves. I just want to point out that POLST is always voluntary for patients. It needs to be voluntary for whether they have one and whether they put it in the registry. But the statute, the laws, can make it mandatory that providers take reasonable steps to assure that POLST, that when a person executes a POLST form, that it will be honored by requiring that POLST form be honored, as we have in statute now, and by, if there's a registry and possible legislation, to require that providers put that form in the registry unless the patient doesn't want it there. There have been lots of other registries that have been created. In California, we have an advanced directive registry in the Secretary of State's office in a file cabinet drawer that's available during normal business hours. It's been in place since 2000. We have few thousand documents in there. There's been proprietary efforts, both with the original tech bubble and now. None of them have taken over the sphere like they had dreams of being. Oregon does have a POLST registry, which Dr. Toll will be talking about, which has been extremely successful. In my personal opinion, it's the only registry I've seen that has really been successful, and so we want to learn from that. Some of the challenges in California, because we are a big state, is the ability, we want to make sure that we're going to be able to match patients' names with patients' records. When an EMT calls and says, I have Jane Smith here, they need to have assurance that that POLST form for Jane Smith is the Jane Smith that they're looking at. We have a fragmented or decentralized EMS system, which is different than what they have in Oregon, so it's just something that we need to look at. And then sustainability. We don't want to start a registry and pilot something if we don't have a strategy and an ability to make it statewide and sustainable long term. As Bob mentioned, there is the POLST Task Force, which had the Registry and Technology Committee. California Healthcare Foundation has conducted a feasibility study, and they're going to be releasing some results from that in the future, and they are doing what we call a kind of scoping effort currently to identify technology platforms and possible pilot communities. So in summary, POLST is a medical order for people who are seriously ill. We have great penetration in California, and a registry is the next logical step. Thank you.
Thank you, Judy, for giving us that historical perspective. Next, we're going to hear a little bit about some research that's been done on the POLST in California from Dr. Neil Wenger, who's the director of the Health Ethics Center at the University of California, Los Angeles. He's also a professor in the School of Medicine and a practicing general internist with an interest in patients with complex illness. Dr. Wenger.
Thank you so much. I'm pleased to be here today to bring to bear some data on POLST in California to inform whether, in fact, a registry might be useful. Over the past 4 years, we have worked with CHCF to evaluate POLST in California. We conducted evaluations of POLST use in nursing homes using surveys and also minimum data set data. Those are the data that need to be collected on every nursing home patient throughout the nation that are being collected here in California to include POLST information. I'll tell you a little bit more about that in a moment. We conducted a survey of hospitals throughout the entire state, a survey of EMS providers by talking with administrators from 20 local emergency service areas, and also derived data from the POLST community coalitions. These were the effector arms for the POLST rollout in California. They provided information to CHCF in their annual reports, in addition some survey data, and those are the data that I'll be presenting to you in the next few minutes. These data, I believe, will briefly show you that POLST is widely used in California. That there are indeed challenges that can be identified with completing the form and making sure that it travels with the patient. And that one solution to these challenges would indeed be a POLST registry. California is the only state where we have universal information on whether patients in nursing homes have POLST forms. This has occurred only because the Coalition for Compassionate Care of California and CHCF together had a section of the minimum data set collect data on POLST on every patient beginning in late 2010. These are data from 2011 that show that of 296,276 nursing home residents in California that year, 98% of these patients, we have data on whether they had a POLST. And there was POLST completed for 63% of these patients. 49% of patients, 142,672, had a valid POLST during 2011. And 13% of patients had a POLST that was missing at least one signature, meaning that it would not be valid, something that perhaps a registry would be able to affect. Drilling down a little bit further into whether there's heterogeneity among nursing homes in having patients complete POLST. Again, these are data from 2011. Now we're looking just at long-stay nursing home residents in every nursing home in California. Let me orient you to this graph. The y-axis is the number of nursing facilities, and the x-axis is the percentage of long-stay nursing home residents that had completed a POLST during 2011. What you can see is that there's dramatic heterogeneity across California nursing homes 2 years after POLST started in California, with 155 nursing homes, that's nearly 15%, having 3% or fewer of their residents who had been in their nursing home for 100 days or more having a POLST, whereas more than 160 nursing homes had virtually every patient have a POLST. This sort of heterogeneity demonstrates that there's differences in procedures and processes in how POLST is handled among nursing homes. Something that might be better regulated if in fact every POLST needed to be turned into a registry. This has great importance. A quarter of all nursing home patients get admitted to the hospital every year. If the POLST doesn't follow with the patient, very often preferences will not be followed. We then surveyed nursing homes in 2012 and asked them about what sorts of problems they had identified in POLST use. Nearly every nursing home was able to identify some issues in the implementation of POLST within their facility. Two of the top problems might be addressed by a registry. One, nursing homes noted that they weren't receiving the POLST form back from other facilities. And two, they were receiving incomplete and incorrectly completed POLST forms from other facilities, making it difficult to carry out the orders. When we surveyed hospitals, and we did a statewide survey of hospitals, we surveyed 286 hospitals, nearly every one of which had had a patient with a POLST form admitted. 47% of these hospitals reported a problem with POLST implementation. Three of the top problems were that the POLST didn't contain the required signatures, that the POLST was incomplete, or that a POLST was incorrectly completed. These problems would likely be affected by having a POLST registry. We surveyed the administrators of the emergency services areas in California. 20 of them responded to us. And as seen on this slide, very few identified problems in their emergency services area with interpreting POLST to make treatment decisions, or in following the orders contained within a POLST document. However, 65% occasionally to often identified the problem of the patient or family saying that the patient had a POLST form, but it wasn't available at the time that emergency services were treating the patient. And an additional 35% said that occasionally to very often, the POLST form that they encountered on the scene was incomplete or it was unsigned, making it difficult to follow in the emergency setting. So what do nursing home patients want? These are data, again from 2011, looking at long-stay nursing home patients in California. As you can see, 57% on their POLST chose to limit the care that they received. 28% indicated that they would not want to be resuscitated and wanted fully comfort-oriented care. And another 29% felt that they wouldn't want to be resuscitated and wanted limited treatment. If this POLST didn't follow the patient back to the nursing home, it's highly likely that default medical procedures would mean that these patients did not receive the care that they wanted. But it's not just statistics. POLST plays an important role in the care received by patients in the real world. What happens if a POLST form doesn't travel with the patient? So this is a de-identified conglomeration of several cases, several real cases. An 86-year-old woman with advanced dementia was transferred from a nursing home to a hospital because of fever and weight loss. The physician diligently met with her daughter, and they decided, after a long conversation, that an extensive workup and burdensome treatment wouldn't be wanted and shouldn't be pursued. The physician completed the POLST form, electing comfort measures only, and left it for the daughter to subsequently come back and sign, which she did. However, the hospital discharge information did not include the POLST form, and in fact didn't document this long extended conversation that the physician and the daughter had had. The patient was transferred back to her nursing facility without any of this information. 2 months later, the patient developed another fever. Her blood pressure dropped. The nursing home staff notified the on-call doctor, who advised them to call 911. The paramedics arrived at the nursing home and transferred her to the nearest hospital, which unfortunately was a different hospital than she had been in 2 months earlier. She was rapidly admitted to the ICU, ended up on a ventilator, and ended up dying there quite a bit later. So in summary, I hope that the data I've shown you is convincing that POLST is widely used in California nursing homes and hospitals. And these are data from 2011 and 2012. It's even more so true today. Nursing homes and hospitals report problems with the flow of POLST forms between settings of care. And the emergency medical services report that there's often problems with the availability of documents at the point of care where emergency services need to be provided. A POLST registry likely would alleviate many of these issues and improve the care that we give to patients. Thanks.
Thank you, Dr. Wenger. So we've heard the history of the POLST in California, seen how widely it's used, but some of the challenges. And now we're going to hear from our colleagues up in Oregon who've had the POLST for much longer than we have and have had a registry, and how their experience has been. So I'm pleased to introduce Dr. Susan Toll, who's Director of the Center for Ethics in Healthcare at the Oregon Health and Science University. She's a professor in the School of Medicine, an adjunct professor in the schools of nursing and dentistry, and is a practicing internist as well. Dr. Toll.
Kate, thank you for inviting me. It is fabulous to be here, and I really have to congratulate Judy Sidko, Thomas, and the entire group in California for the unbelievable speed with which you have implemented POLST in California and the remarkable nursing home data that you have to share. It's special to be here and to be collaborating with all of you when you are so clearly poised to move to the next level, because you're widely penetrated enough to be able to do so. And it's fun to be here on the anniversary of our 5-year launch of the Oregon POLST Registry and tell you what we've learned, what seems to work, and what we've learned from our colleagues that doesn't work as well. But before I do that, I want to remind everyone that I'm from Oregon. And in doing that, I want to make a clear distinction between some things that are legal in Oregon and the POLST program. Oregon passed almost 15 years ago the Death with Dignity Act. And to date, 2 people in 1,000 who die use the Death with Dignity Act. I have chosen, and the people with the Oregon POLST program, to focus our energy on the other 998 who make decisions about life-sustaining treatment and whether they would like to step aside and let nature take its course. They would like some treatments and not others, or they would like to have everything that medicine has to offer. Every state allows people the choice of refusing certain treatments. in the context of advanced illness. Ethics, which I direct the Center for Ethics in Healthcare, does not consider that to be controversial, that people would have a right in some situations and circumstances to say, I'm no longer going to have some of these treatments. Very different from the controversy about deliberate acts to move the time frame up and shorten your life. The POLST program is completely separate from and designed to recognize that right to make choices for yourself about treatments that may or may not be effective and you may or may not want. But I want to make a clear distinction because when I'm from Oregon, I'm here to talk about the POLST program. And I want to make it very clear that those are two very different things, and what a large number of people utilize the POLST program and what a very small number of people at 15 years, it's less than 1,000, who have used the Oregon Death with Dignity Act. And you'll see that in 5 years, just in the Oregon POLST Registry, over 200,000 POLST forms have been submitted. So I want to just clarify where we're going to focus our energy today, which is on having or limiting treatments and the freedom to do exactly what makes sense to you in the face of advanced illness. I'd like to begin by showing a 4-minute video that we shared just as we were developing the Oregon POLST Registry 5 years ago, about what a registry could do and how it could move you upstream and out in the field with information before treatments were started and answer exactly what Dr. Winger said about the woman with advanced dementia in the nursing home and the problems we have with portability from one setting of care to another. And to me, EMS is actually a setting of care. And their authority and jurisdiction and regulations is different from the long-term care facility and different from the hospital. So you need 3 steps in the process for the woman who her and her family and her long-term wishes were to limit certain treatments, but where that didn't happen, and how far upstream you need to get and how quickly you need to have that information available.
Mary and her friend Maxine like to spend time outdoors, growing flowers and vegetables in their retirement community garden. It's sunny and warm today, and the women are harvesting tomatoes. Mary, who is 84 and has significant medical problems, begins to feel the heat as she climbs the stairs toward her apartment. Suddenly, she collapses, and Maxine finds her on the grass. She calls 911. Within minutes, an ambulance and rescue vehicle arrive, and paramedics tend to Mary, who is barely conscious. While they're assessing her condition, they ask if she has a physician orders for life-sustaining treatment form, known as POLST.
Does she have a POLST form?
She has a POLST form. It's up in her apartment.
Since Mary's apartment is some distance away, one of the paramedics phones into the electronic POLST registry for her medical information.
Yeah, we have a Mary Hughes. She lives on Holy Names Drive. Date of birth is 5/11/24, and she has a POLST form on file. Could you get us the information for us, please?
Mary's POLST orders are do not resuscitate and limited additional interventions. Based on those orders, EMTs assess her injuries and prepare her for transport to a hospital where a faxed copy of her POLST form will be available. This scenario is a dramatization meant to illustrate how an electronic POLST registry now being established in Oregon would allow patients like Mary to receive the interventions they want and say no to those they don't, even if they cannot speak and their written orders are not close at hand. Paramedics tell us that situations like this one are not uncommon.
POLST is a written order. That's the standard that we want to find at the scene. We cannot withhold any treatment that we're capable of giving without a legal document that authorizes us to withhold that. as we're working on the person, I think if this was me, I wouldn't want this to be happening right now if it was my mother or father, but without legal guidance, we have to do everything within our ability regardless.
Emergency physician Terry Schmidt is helping to develop the registry. She explains to paramedics how information on POLST forms in the registry will be shared with authorized emergency personnel while still protecting patient confidentiality.
I think a registry is a terrific idea. It's late in coming, if you ask me. I could have used this years ago. The sooner we get it in use, the better off we'll be, and better off the patients who have POLST will be.
I want to thank you for coming to my rescue.
Thankfully, Mary suffered nothing more serious than heat exhaustion, and after evaluation and IV fluids, is back in her apartment.
It's really great that my wishes were carried out, and the registry for the POLST form was available.
Glad to hear that it works.
Yes.
One of the things that we learned right off was, and it motivated us to create the Oregon POLST Registry, was in 2002 we surveyed EMS providers from all across our state. And what we learned was that 25% of the time when they were at the scene in a crisis, the form was not immediately available. Sometimes it was later found in papers. Sometimes it ultimately appeared, but immediately as they first arrived, 25% of the time, and we surveyed over 1,000 EMS providers for this study all across all counties in our state. And we knew that we had a problem with something that appeared to be working very well, be very effective, but not always be where you needed it because you needed it so quickly. 5 years ago, today, we established the statewide POLST registry. Earlier that year, we did a one-county pilot and developed the programs and the systems and the educational materials, including movies, to be able to educate everyone as we went out to build the registry. This is actually a screen inside our statewide trauma system, which is where our registry lives, showing a POLST form called up on the screen. It's actually the same person's that was in the video. We had done an enormous amount of outreach education to get ready. We had 600 people that we called change agents in action. One person in every hospice program, nursing home, and hospital, with modules that they played the month before we went live. We did intensive education of EMS, and within the first month, we began loading 3,500 POLST forms a month in a state that has 10% the population you do. So for you, that would be 35,000 POLST forms a month. And it's been steady ever since. The curve is consistent within a couple of hundred every month. The number of forms submitted is over 200,000. Some people have more than one POLST form, so it's not 200,000 people, and it's not 200,000 living people. But over the 5-year period of time, that's the volume. For you, that's going to mean in 5 years, over 2 million forms. So we need to think about how can you find people quickly. We need to think about why you would only want to have POLST forms in the registry and not a lot of other pieces of paper or other kinds of documents so you can do your search functions rapidly. EMS tells us that they appreciate just finding orders and not other papers in the confusion. To have a system that worked as well as the curve I just showed you means a lot of factors that we'll come back to in a minute. But the motivation to have it became much stronger when we had the opportunity to look at data from the first 2 years of registry operation, match them with death certificates, and find out where people died and did it matter what you marked. I want to give credit to first author Dr. Eric Fromey. I'm the senior author on this study, and to the entire POLST registry team who had the opportunity to do something no one else can do. Every setting of care across the state, every county, everyone submitting and being able to look at death certificates, which can tell you location of death, and POLST forms, which can tell you the categories of orders that were described about, I want everything possible in Section B. I want limited treatment. I want a focus on my comfort. And does that matter? Does it make any difference in the outcome? There have been many studies in ethics, including about advance directives, that have said it makes very little difference where you die, whether or not you have an advance directive. Advance directives are wonderful and do very important things. They help you appoint a surrogate. They lift a burden from your families. They have little impact on where you die. The workhorse of the POLST program is Section B. Why? Why not Section A and resuscitate? Many in the general public do not understand that resuscitation is not like what they see on TV. If you are a POLST eligible patient, if you have advanced illness and frailty and your heart stops and you stop breathing away from a health system, out of hospital, your odds of resuscitation are 3% or less. And that's just getting your circulation and pulse back. That's not surviving the hospitalization. That's not returning to your prior state of health. If you watched television, you would think at the end of 30 minutes, the odds were in your favor. Your hair would look great. You would be resuscitated by beautiful looking people, and the music would all be playing. So the general public thinks that it's really important what happens in Section A. But in general, we will attempt resuscitation where you wanted it to happen. And in general, you will not survive. So what happens about location of death for people is in Section B. That's where the power is. We published this study this summer in the Journal of the American Geriatric Society. This is 18,000 patients in the first 2 years of the Oregon POLST registry operation, matched with death certificates from only people who died in Oregon, and looked at what you marked in Section B and where you died. If you did not have a POLST form, that's the bar graph to your far right, no POLST form, the rate of death in hospital was 34%, which is lower than the national average. If you marked comfort measures only on your POLST form, your rate of death in the hospital for the over 11,000 people who marked that was 6.4%. Should it be 0? You said you didn't want to go back to the hospital. No. Why? Specifically on the POLST form, it says, unless comfort measures cannot be managed in the current setting of care. I'm a general internal medicine physician. I would say that about 1 time in 20, I cannot manage your suffering at home. Something goes not as we would have liked. You will not stop seizing. You fell, you broke your hip. Something happens where your suffering cannot be managed. We need to transport those patients, and we need to protect that that option is always available when we can't manage the current setting of care. So I had guessed if we were right on target, it would be 5%. I was astounded at 6.4%. It is so close to what really should be happening. Now, this is not just about having a form and checking a box. It's about having a program. It's about having extensive educational programs. We made that whole movie, there was no registry. It was all what's going to happen, and we were ready to roll all that out right before it started. We were ready everywhere with education. It's about the quality of the conversation, just like Judy Thomas said, because if we can do an excellent job of assuring you get what's checked on the form, hopefully indeed that is exactly what you wanted, and that you understood that in a full way, and that it was ultimately respected. If you say you want full treatment, everything medicine has to offer, I don't interpret that as saying, I wanted to die in the hospital. I interpret it as I wanted to continue treatments to try to extend my life. However, you greatly increase your odds of dying in the hospital. In fact, you increase them to a level that's 10% higher than having no POLST form at all. Wanting limited treatment is intermediate between the two. You wanted to go back, you wanted to fix the easy things, but there were certain limits you were setting. It made perfect sense. It would be intermediate between the two. So what we found was what you marked was very, very much associated with where you died. More so than any other study that has been done about any instrument related to end-of-life planning. Increasing interest across the country in the POLST program and increasing interest in being able to find the form. If it works this well, let's find it. In a crisis, EMS in the field, just like in the movie, calling the registry and finding a match, we've had over 2,000 matches of people in a crisis. We've also had many more POLST forms be able to be located ahead of the crisis and available through the back office before things became in extremis and it's EMS calling. So much more availability, much wider education, much wider use. We now know that every hospital, every long-term care facility, and every hospice program in Oregon use POLST for at least some of their residents. We want this to be a voluntary program. I get a little nervous when I see 100% use. I'd like to summarize some of the lessons we have learned, and happy to answer further questions. But there are a few really key things that I encourage about a registry to make it as effective and work as well as ours has. I want to tell you that some registries have floundered. To the north, my colleagues in the state of Washington had a registry. They had a similar amount of money that we had, and they have a slightly larger population, from the state to support their registry. In 4 years, they had a total of 4,000 forms. Remember, we load 3,500 a month, not in 4 years. It was freestanding. It wasn't linked into healthcare. It had all kinds of different documents in it. But we can really learn from our Washington colleagues about what did not work well. Completion, as Judy Thomas said, needs to remain voluntary. You don't have to fill out a POLST form. You can mark it any way you want to, and you can change your mind. 1/7 of the forms we load every month are revisions of existing forms. This is a living document. It's also important to realize that if you mark comfort measures only, it doesn't mean there's nothingness. It means there's a whole plan of care for your comfort in your current setting, which may be hospice, may be many other things, but it's not that there's no resources. There are different resources. Providers must submit. The mandate to submit is a cornerstone of our success, and the mandate is on the healthcare professional. The patient can opt out and say, I don't want to be in the registry. Most patients say, why wouldn't you want to find it? And so landslide, the majority, it's about 1 in 1,000 don't want it. Helpful if it operates statewide. much more effective. People move from one setting of care to another. And it's helpful if it operates deeply inside of healthcare, if it is part of healthcare. We have a statewide trauma system and EMS. You do not. Our statewide trauma system is where the heart of that scene that I showed you, calling up the form, lives inside trauma. It was already a 24/7 call system and was very effective, but it needs to be at least part of the workflow of healthcare professionals. The POLST program, recognizing many things that have been developed here and across the country, and specifically the JAGS article from this summer on effectiveness, in the Institute of Medicine report, clearly recommended the implementation of POLST programs, which are very advanced here. But you all will soon be seeing other states who want your mentorship and want your guidance. And Judy Thomas actually chairs the National POLST Paradigm Task Force. This is what the national map looks like. And my guess is that within a year, California will be the third mature state. And mature means that wherever you are, you have access. There are not holes in availability, even though you have a functional program. Lessons learned. Do not build a freestanding system. Link it tightly inside healthcare so that it functions within rather than freestanding like a file cabinet with advanced directives that I didn't even know about and I've studied. I thought everything you all had. For years it had been there and I did not know, suggesting not well integrated and not probably what you want to invest in. You will need to plan for and launch enormous statewide education concurrent with launching your statewide registry. You'll want to keep the focus on honoring wishes. Everything we have done is about what the individual wants. And it's my strong belief that those who wanted full treatment didn't save any money in healthcare. It's about what you want and who you are and your ability to change your mind. In summary, research shows the effectiveness of the POLST program in honoring patient wishes to have or to limit treatment. And many people want some things and not others. It's not all or nothing, as Dr. Winger showed in his slides. The Oregon POLST Registry ensures orders can be found in a time of crisis. We have a magnet system. It's on people's refrigerators in a private home. If you see the code, it takes 15 seconds in the phone call to match. It takes about a minute and a half if we're matching all of the demographics of someone found down to link it to the registry in the search functions. But very fast in a time of crisis in real time. One of the greatest joys for me, besides knowing that we are truly honoring people's wishes and what they deeply wanted, is lifting the burden from families who had thoughtful conversations, like the case described by Dr. Winger. The family had really made a heartfelt, thoughtful decision, and we are avoiding them coming into the ICU and now withdrawing life support that they never wanted to have started. They carry that with them, and many feel they let mom down. It's a wonderful thing to do to get ahead of this. And I'm happy to answer your questions when it's open for question and answer. Thank you.
Thank you, Susan. We're now going to go to the question and answer portion of our briefing. We have a couple of folks who have microphones. We ask that everyone wait until the microphone is available so those on who are listening to this remotely can hear your questions. And then so if you raise your hand, someone with a microphone will come by and I'll recognize you before you speak. Just a quick reflection on thinking about this. It's very inspiring. I'm hoping you all felt inspired by hearing the stories of Oregon's success. And yet at the same time, it's a bit humbling to hear about some some of the critical differences that California has compared to Oregon, and so it gives us a vision of what we could do, but also gives us a sense of the amount of effort we're going to have to put in California in order to make this happen. So that's just my reflection on listening to the three presentations. The first question. And please introduce yourself for the audience, too.
Lyman Dennis, Connect Healthcare and HIE. One of the lead time items is getting the mandatory submission legislation. I was wondering what the status of that might be for California.
Judy?
The legislative session for the current legislative year has just started. So there has been one bill introduced by Senator Wolk. There's still quite a period of time, and last year we saw more than one registry bill, so we're just at the beginning phase for the current session.
Hi, I'm Maribel Barajas with Senator Lois Wolk's office, and it's not more of a question, it's more to answer your question. So Senator Wolk introduced AB 3000 that brought the POLST form to California. Last year, Senator Wolk introduced 1357, which created the POLST, which would have created a statewide POLST registry, but it was held in committee. Because we know the importance of ensuring we honor patients' end-of-life choices, Senator Wolk decided earlier this week to introduce SB 19, which would create a statewide POLST registry again. We've had bipartisan co-authorship on the bill, and we look forward to working with all of you. We know that you have a lot of input, and we'll need your support to ensure that this bill is successful this year. And we have fact sheets and copies of the bill. And if you have any questions, feel free to call me at Senator Wolk's office.
Thank you. Good afternoon. Amber Salazar, WellSpace Health. I'm just wondering if the form can be signed by a mid-level provider, such as a FNP. Is that appropriate, or does it have to be an MD?
That's a good question. That one I can actually answer. Currently in California, it does. The nurse practitioners, physician assistants, midwives are not permitted to sign the POLST registry. Other states do allow that. Anything else, Judy, you want to mention on that?
There is variability by state. Oregon does allow nurse practitioners and physician assistants to sign. 15% of the forms in the Oregon POLST registry are completed by nurse practitioners and PAs in Oregon.
Great. And then over here.
Hi, Mohsen Sadat, San Joaquin General Hospital in Stockton. Susan, I was wondering if you can share with us some of the challenges that you met going through this program and similarity that we may have here. Especially if you can talk about EHR a little bit, all the different EHRs and how basically personalized they are and very difficult to deal with some of them.
Well, as a practicing physician, I can talk about the fact that there are challenges of EHRs. And the biggest one with relation to POLST is that often things are not interoperable. So we have a state with a lot of urban-rural division, and certainly our long-term care facilities are not using the kinds of medical record systems that our major health systems are using. So electronically, they are indeed not interoperable, and that is not a way we were able to solve the problem. And I don't foresee that changing really quickly to create a way that there could be finding of forms because of a uniform EHR system. I just don't see that happening anytime soon. When we're thinking about reaching all the way into a private home for hospice and for people in assisted living in a small setting, it's going to be a long time before they're even electronic at all. So we felt that a registry was a real answer to that challenge. We piloted ours in one county early in 2009 and then launched December 3rd, 2009. So we only had about 6 months, because things went much faster in our legislature than we were anticipating. And we were also quite surprised because it was in the middle of the recession, and the state funded the registry out of the general fund. We did not think we would make it in the first round, and so we thought we were going to have longer in the pilot. But we can tell you one incredibly important lesson we learned from the pilot, and that was that the pilot did not have a mandate to submit because there was no statute. The pilot was voluntary. And while nursing homes would submit existing POLST forms, and there was enough work that we could figure out what we needed to do to make the system work pretty quickly, what we found was that healthcare professionals complained bitterly that without a mandate to submit, they needed to sign additional paperwork and releases, and that it took too long. And therefore, they did not tend to submit forms in the way they did immediately after the legislation that offered the immunity, just like the immunization records immunity. If you have a mandate to submit, you don't have to get a release to submit. So the time for counseling about the details of the release has gone much more smoothly when we simply have an opt-out box. And if you don't want to, we check the opt-out box, it's all done, it isn't submitted, but it is not a long process about the consent and sending the form in, which was not well received by healthcare professionals and greatly reduced use and is a huge part of what was wrong in the state of Washington. So the mandate to submit is invaluable, and we know because we tested it both ways. I'm also aware it's in the statute that's been proposed.
That's a great question. It also gets at that aspect of can we use technology to help with some of the issues, and that's probably going to be one of the biggest challenges in California. So, actually, I'll come back to you.
Pat Blaisdell from the California Hospital Association, and thank you for a great presentation. I certainly understand a lot more about this than I did an hour ago. My question is also for Susan. In regards to the mandate, I'd be curious as to who is subject to the mandate. Is it the individual who executed the POLST and signed it with the patient? Is it the residential or medical care facility? And I can see that being an area of some confusion.
And that's in regs, so it wasn't in the statute. And the regs clearly allow it's the signer, the obligation is on the signer, but you can designate. So for example, medical records at the Oregon Health and Science University is submitting in my behalf. So the health system main record system for the larger systems is submitting. In clinical offices, it's often their medical assistant who is submitting in their behalf. So it can be your designee, and it almost always is.
Good afternoon, Jed Hampton with Leading Edge California. I had a question specifically for Dr. Toll regarding the financial burden to the state, specifically the ramp-up costs and the annual operating costs of the registry.
The state did not pay any ramp-up costs. We did that with private philanthropy, and we built the system and tested it with private philanthropy in the pilot. So the state's involvement began after the pilot and on the 9th of December 5 years ago. And the funding level has gone up to about 5% per year. Our first year, it was $350,000. And that would mean $35,000 for all of you in California, since you're 35 million. No, wait, 350,000, 3,500,000, because it's 10 times as much. Thank you. But and that did come out of the general fund, and still does. It's very hard through any kind of private philanthropy to imagine sustaining forms being entered, phone calls being answered for a state that it just doesn't make sense once you're past development to think that private philanthropy would sustain this. It really does need to be sustained, I would recommend, out of the general fund. And we did that from day one. once it launched, that's because the development phase, you may want private philanthropy to modify some of the aspects in the pilot and move in a kind of a quick way to make adjustments.
A question? While we're waiting, I'll ask a question for the panel, if anyone. There are other lessons learned from other states besides Washington that you mentioned. Are there any other lessons learned that would be valuable for those of us in California to be aware of, other than the ones that you've mentioned so far? Maybe Susan and then Judy.
You want to go first? Good.
Okay, well, so some lessons from some other states. In Utah, they did get some funding to do a beta testing and get their program up and running, but they haven't found sustainability for it. So I know in California, we're very interested in the long term. If we're moving forward with this, we want to make sure we have a good strategy on sustaining this long term so that we don't lose that momentum. West Virginia also has a good program, which Susan can probably comment more on, and they have taken a different approach where they do have multiple documents in addition to POLST that can be submitted to it.
I would be glad to talk about West Virginia. I think it's the second most effective registry. It's well integrated. They used our programmers to build it, and it does have advanced directives and POLST forms. It, however, has about, based on the population, they're smaller than we are, less than 10% the number of forms being submitted, even though they're established. What have they done wrong? There's no mandate to submit. And so that is a struggle. They do have funding from their state and general fund money, and they are operational. And there will be data, it's unpublished, about why I am telling you don't put advanced directives in it from his registry, and you'll just have to trust, because it's unpublished data, that has not proven to be a very good investment in West Virginia.
I'll ask another one then. There's in Oregon, it's communicated, it's faxed in. Are you exploring an electronic version so that using modern technology to use an electronic version? And if so, how is that going?
We realize that the way of the future is clearly electronic. We also realize that with an electronic registry, we would be able to reduce what Dr. Winger talked about, the not correctly completed forms. We have 6% of our forms, for example, that are missing a date. No medical record can be dateless. What if I end up with 2 forms? Which is the one I should be following? That just is not a functional situation. If you're electronic, you can put hard stops on it. You can make it automatically fill the date it's signed. You can put all of those changes, and we are very hard at work, actually with a team that is in the room, designing a pilot for a system that would do electronic and be adaptable for the rest of the country. And we are not yet up and running in the pilot phase, but we are really close. And we would hope that would be available to everyone. We would like to have it be the kind of thing, you can do this with a smart set inside an Epic system. And actually one of our health systems in our state has done that and is submitting. But that is not, then it works for that smart set, for that system, and does not allow you to integrate everybody with different kinds of record systems or competing health systems. So we want to take it to the next level, and that is the future.
Great. A question in the back?
Hi, thank you. And I think you got into this a little bit. Hi. First, I wanted to clarify which agency, is it the Emergency Medical Services Agency in your state that actually controls or runs the registry? And then also what you meant by kind of integrating it into healthcare delivery versus a freestanding?
First of all, EMS is by county here as best I understand things. In Oregon, we have a coordinated statewide EMS system. And that system coordinates our trauma transfers, for example. And the center that coordinates our trauma transfers for the state is the same place that pulls up POLST forms. And so they're already online with the EMS. They're already on EMS's speed dial. So that has made it a very efficient system that was already 24/7 for us to put inside healthcare and be also quite efficient. And it meant that there weren't two different phone numbers for emergency medicine to try to remember or use. There's one that they already had. So that would be quite different than what you would be doing at a county level, and how you would solve or integrate would be something that applies to many other states, but where your state will be designing a model that recognizes that you don't have an integrated statewide trauma system. But you want to have healthcare professionals not going completely outside of their normal workflow. And the more it can be part of this electronic system they normally use, the more it can be part, which is what we're trying to bring it back in and make that piece also link in, the more they will use it, the more it will be current, the more it will be integrated. And freestanding means it is somewhere completely unlinked to any aspect of healthcare and is a repository. Then by trying to protect access to it, you end up putting up lots of barriers because you can't allow a search function. We can't allow you to come and figure out which Harriet Jones you have found down because of HIPAA. You should only be able to access the person you know and need and match. But to make the found down work in the field means you have to have search functions. Well, who's doing the search function is on the other side of the firewall for us. So you call in and the search is being done by the trauma system. So there are only 14 people who have access to our records that work in our trauma system, and it allows a search to be done. Otherwise, you need a medical record number, a passcode, or something to keep the searches from being done. And if you're doing that, you won't have the passcode in a time of crisis in most cases. So how you get the searches and how you protect privacy are complex, which is why I said it has to live somehow inside healthcare.
You've talked a lot about, registries that have multiple documents versus, just the POLST form. Can you expand a little bit? Because given that, the capability to electronically and pull forms and identify them, I'm still wondering, what the pros and cons are of the different types of registries.
But that may be a good question. I'll let everyone answer that, and that'll be a good way to wrap up.
A good way to end.
Yeah, go ahead, Susan, first.
First of all, the National POLST Paradigm Task Force has a national consultation from EMS and has asked, is it helpful to EMS in the field to have an advance directive as well as a POLST form? Is it good to actually get both things in the field? The bottom line is they can only follow written orders, and if they have too many pieces of paper, they become confused. And our advice from our national EMS colleagues is don't give them the advance directive in the field, give them only the POLST form. So that's one aspect of why the mixed documents. The other is data that will be publicly available in February, presented by West Virginia, about how having both documents in a registry works or does not work, and why I know so strongly that the power is with having POLST orders in determining whether or not patients get their wishes followed. Advance directives are on a longer timeline. You don't need them immediately because EMS can't use them immediately. They need to be interpreted in the context. I have one. If as I'm going back to Oregon tonight, something bad happens in my travels, I have an advance directive. I do not want EMS to pay one bit of attention to it. I have a lot more work I hope I can be doing. So it needs interpretation. It's not for immediate use. It costs money to load up forms and keep track of them and sort them. If one document is far more effective in a crisis than another, then investing your limited dollars in the most effective system is what Oregon has decided to do, and what national data is showing is far more powerful.
Dr. Winker?
So I might comment from a clinical perspective. It's very important to be able to collect in some way wishes for future health care in a health state that's different than one's current health state. That is a job that electronic health records should be doing far better than they are now, and should be preserving that information, as Dr. Toll said, so it can be used at the time it's necessary. That's a very different task than having actionable orders available when they're needed, which is why a registry ought to only include something like a POLST.
We put advanced directives on the main header of our electronic system, so it says POLST yes, no, advanced directives yes, no. Because once you're in the hospital and you're having a family meeting, you need these documents. But the major large health systems all have ways to find them now and store them and share them, because that's when you need them.
There's actually, I think, there's some federal regulation around the ability to capture and retrieve advanced directives currently in medical record systems in the hospital. Judy?
Yeah, so just to add with what Susan said, I think another piece that was implied in the response, another piece that was the reason for their success is they were really clear on who their audience was for the registry. And that's part of the question. Who is our audience? Is it EMT and emergency responders? Is it the folks in the emergency department? Is it the entire healthcare system and stream and continuum? Those are different parts of the healthcare system have different needs. And so I think getting clarity on who our audience is, and that the more clear you are, the more likely you are to meet the needs of that very specific part of the healthcare system. The other piece is, just from a practical standpoint, I mean, POLST is a standardized order. It's a standardized form. So when it gets entered in, you can pull out data elements. You can process it. You can make sure that everything's answered correctly. Advanced directives, there's as many versions as there are people in the state of California. That's fine. So it requires a different way of processing it from a practical system standpoint. So that's one reason why, I mean, even if you did have a registry that had multiple forms, the POLST would be handled and processed very differently than the other forms.
Great. I'd like to thank the panelists for their great presentations. This is really an all-star crew that CHCF brought together, and it was a wonderful presentation. I'd like to thank CHCF for putting on this legislative briefing. Remind you all in the audience to fill out the evaluation of today's event, and thank you all for joining.